Okay, welcome to lecture number 5 in our GRC lecture series. This one is Mental Health Considerations in Older Adults, presented by Dr. Rikki Patton, who is an associate professor in the College of Health Professions at the University of Akron. And with that, I'm going to go ahead and let Rikki get started. And remember that if you have any questions, you can put them in the chat, or we do have from 1 o'clock to 1:30, we have time set aside for discussions and questions. And that can be questions about the presentation, as well as any questions you have about the GRC program, the LMS, or anything like that. So with that, Rikki, if you want to take it away.
Thank you so much, Denise, and good afternoon, everyone. I want to thank you for the opportunity to share a little bit with you about mental health considerations in older adults. And I want to echo what Denise said. Please feel free to put things in the chat as we're going through, and we can make sure to address things in real time. All right. So Denise already introduced me a little. I just wanted to also fill you in a little bit on my background and my role in working in the topics of mental health with the older adult population. So I am a faculty at the university in both the schools of social work and school of counseling. And my credentials, my clinical credentials, are that of an independent marriage and family therapist. So I approach things from a relational systemic perspective. The thing I say to my clients all the time is, I understand you don't exist on an island or in a bubble. So I ask about your web of relationships. That helps me understand you and your context more. And I think that's very true for our older adults as well. I've also been honored with the opportunity to be a member of the GWEP team for a few years now, and getting the learning experiences from that, and the interactions with learning about older adults and being able to contribute from my areas of specialization. My areas of specialization, I focus mainly on substance use disorders from a relational systemic lens, and a lot of my clinical experience with older adults is working with older adults who are in recovery or who are working through their own recovery based on a loved one's addiction, so a partner or a child. And I do a lot of couples work with older adults or family dynamics with older adults. And my clinical experience has included intensive home-based treatments, and those are usually geared more towards younger folks, adolescents, and children. But oftentimes you're working with multiple generations in that system. And I've also engaged in private practice and doing some different levels of integrated care in both my private practice and in a primary care setting, and then supervising trainees who are working in integrated care settings and working to integrate mental health into medical settings. So hopefully that helps in terms of just understanding me and where I'm coming from. For our webinar today, the next 55-ish minutes or so, we're going to talk about the prevalence rates and correlates of mental health in older adults, define some of the common mental health diagnoses. We only have an hour, so it's going to be kind of a broad stroke with some of the more common issues that our older adult patients may be experiencing. We'll also consider the caregiver and what are some of the factors that we need to be accounting for there, and then focus in on integrated care and the role of your behavioral health team members on an interprofessional team. And then, as Denise mentioned, we'll open it up for question and answer. So the hope by the end of our discussion today is that you all will be able to identify the mental health prevalence among older adults, identify those common diagnoses and how they impact this population, describe some of the common assessment and intervention strategies that we'll use in behavioral health, and then explain how behavioral health professionals can really be a part of the interprofessional team. All right, so let's dive into the good stuff. So we know that the older adult population is a growing population. The World Health Organization tells us a little bit about global prevalence with reports that there is going to be a nearly double by the year 2050. And then national rates using Healthy People 2020 reports show, again, another significant increase from 2014 at 14.5% of the population to about 24% of the population by 2060. And even here in Ohio, we know that our older adult population is a significant component of our population at 16% of the population. Thus, we need to be talking more about how are we addressing the needs of this very significant component of our population, both for their physical health and their mental health. And I just said that. So mental health specifically is a public health concern for our society as a whole, but particularly for our older adult patients for a multitude of reasons. One, prevalence rates are particularly high. World Health suggests that about 15% of adults age 60 or older are experiencing a mental health disorder, with Centers of Disease and Control reporting 20% of folks experiencing some type of mental health concern. And then the National Council on Aging has looked at both mental health and substance use disorders, and reporting approximately 1 in 4 folks who meet that diagnostic criteria in our older adult population, and that the sheer numbers, the actual numbers of older adults meeting criteria for mental health or substance use disorders is expected to double between 2010 and 2030. We also know that there are some common mental health diagnoses among our general population and among our older adult population. Specifically among older adults, some of the more common diagnoses that we see come across in their files and such includes things like anxiety, cognitive impairment, mood disorders, which oftentimes encompasses depression, dementia, and substance use disorders are the common ones. So we'll focus mainly in on those today. And we also know that mental health is more than just the diagnoses that come from the ICD-10 or the DSM, that there are other mental health considerations that we need to consider when we're thinking about our work with older adults. That include social and emotional supports. How are they perceiving the support that they're receiving or able to give? In addition to, it links to loneliness and isolation and the impact on or the ripple effect into other parts of their life, including their overall mental health and physical health. Their general life satisfaction, again, noting that that has a ripple effect on their overall wellness as well. Broader mental distress, so this idea of just stress existing and there being kind of global lifespan stressors in addition to some unique stressors that our older adult patients experience. And caregiver stress, both for our patients who are caregivers or for the caregivers of our patients. We need to account for that. And considering those contextual factors, the systemic relational factors that play a role in the stress and distress that our patients may be experiencing. With all of that, we know that there is high prevalence of mental health and substance use among our older adult patients, and we know that there are common diagnoses. We also know that mental health impacts just overall wellness and is correlated with a few other factors. One is the recognition that nearly 7% of total disability is linked to mental or neurological disorders for our older adults, and that mental health issues are oftentimes linked to as a factor in cases of suicide, with older adults being at high risk for suicide. They're a vulnerable population for it, with older men, particularly older white men, being most at risk. Some of the stats suggest that the suicide rates of men aged 85 and older, that being our most vulnerable population, is at 45 per 100,000, and that's compared to 11 per 100,000. So that's a significant difference. And again, we know that suicide is linked to mental health issues, poor mental health prognosis. So we can mitigate some of that by addressing mental health head on. And there are several risk factors for mental health issues among our older adults. So this is something that I touched on earlier, but I want to dive into just a little bit here. One are general stressors across the lifespan. Oftentimes any transition, any lifespan type of transition can increase stress, which could increase our vulnerability to mental health symptoms. But there are also specific stressors that are more common in older adulthood that may trigger mental health symptoms. This includes chronic pain being a common one, a reduction in independence that might be mobility related to that, or virility or other health problems related to that. Bereavement can be a risk factor for older adults, knowing that there's increased experiences of bereavement. And in addition, the idea of the impact of retirement and how the ripple effect of retirement takes away purpose and work, and the factors that oftentimes do give people purpose and meaning. But also there's a change in socioeconomic status, which can be a huge stressor. And there's increased isolation, increased loneliness, and increased overall distress as we age potentially. And those are all risk factors for increasing mental health issues. Additionally, we know that there's a reciprocal interaction between our physical health and our mental health, with one of the most commonly researched or studied linkages being heart disease and depression. So the connection between increased heart disease equals increased depression and vice versa. There are other studies out there that show increased health problems overall equals increased mental health problems as well. So it's something for us to keep in mind that for our patients who have chronic illness or other physical health issues, that they may be more vulnerable to mental health symptoms as well. And older adults can be vulnerable to elder abuse or other traumas, with some stats saying one in 6 of our older adults may experience elder abuse. So experiencing abuse or trauma is also another significant risk factor to increased mental health symptomology. And excuse me, we'd be remiss not to point out some of the special considerations for mental health right now in 2020. What a unique time, right? But COVID has had unique impacts on mental health and relatedly social isolation for everybody, particularly for our older adult population. So as it relates to mental health, we recognize that symptoms have been exacerbated by the ripple effect of COVID. There's increased stress about COVID, period. The uncertainty related to it. What does this vaccine mean? All of those types of things. And there's also the worry or even the potential for being more vulnerable to COVID and the potential adverse effects on it, and increased physical health symptoms related to all of that. In addition, we know stay-at-home orders, all of those have impacted social isolation. So social distancing has impacted connectedness, the impact on routine. So I know a lot of my older adult patients had a very rigid routine daily. This is what we do daily, and that changed significantly, which definitely ripple affected to their mental health. And then again, the array of losses. So maybe it is losing that Sunday dinner they had every week with their grandchildren, or even the death of loved ones due to COVID or some kind of complication, and the loss of autonomy or roles or choice because of some of the restrictions related to it. So something else to keep in mind as we're talking through this is that we have these additional special considerations with COVID and how it impacts our older adult patients. So knowing all of that, we have relatively high prevalence. Mental health is a public health concern. It's related to other correlates, the ripple effect into physical health, the ripple effect into other issues for our patients. It's also a public health concern because there's a significant treatment gap. So depends on who you ask in terms of the numbers, but some reports suggest that up to 2/3 of older adults who have mental health symptoms do not receive the treatment they need to help mitigate those symptoms, and that preventative services for older adults are limited, that the funding, the resources aren't being focused on mental health prevention or health promotion for our older adults. And in addition to that, not only are folks not getting the services, there's a few reasons for that. And part of it is that oftentimes substance use disorders and mental health disorders may be overlooked, misdiagnosed, underidentified and that's by us as health professionals and by the patients themselves and their loved ones. And there are a lot of reasons for misdiagnosis or these diagnoses being underidentified. One of them is the stigma related to mental health. We know that there are cohort effects with mental health stigma, so that older adults are less likely to seek out treatment anyway because of the stigma connected to. But also there's that stigma that, you know, depression is just a normal part of aging, or you just have to deal with it, or why are we going to take away his beers? It's the only thing that makes him happy, that whole bias or that whole stigma. And those are factors that feed into this treatment gap or exacerbate symptoms or allow those symptoms to continue on our patients. So we need to be mindful of those stigmas, do our own self-reflection. What stigmas might we be carrying about mental health or substance use for our older patients? And how do we challenge those for ourselves and for them and their loved ones? All right, so knowing that there's a significant portion of the older adult population that may have symptoms for substance abuse or for mental health or I should say, and that most may not be receiving treatment, we need to recognize what's that ripple effect here. And we know that untreated substance use and mental health problems have lots of ripple effects. One, it links back to physical health. It's linked to poorer health outcomes. So a common, I'll talk about this in some of my case examples, but a common linkage that I experience with some of my cases in primary care is like it's non-compliance with diabetes treatment or non-compliance with heart medications, and that being linked to depression or that being linked to anxiety. Both are kind of spiraling at the same time. Also higher healthcare utilization. So carrying mental health symptoms, those are heavy. They're so heavy, and they impact physical health. So if you have both of those spiraling, these are our patients who are going to be seeking out our services more. Thus the reason for screening all of our patients for mental health and substance use. That was my plug. Right. In addition to that, we know for older adults that there is a complexity in terms of the illnesses that they experience and the prognosis. If they have untreated substance use or mental health, these are going to be exacerbated. The course of prognosis for many of the physical health diagnoses that they may be experiencing is going to be poorer. May also increase disability and impairment. So some of the symptoms related to particularly substance use, but also mental health, may increase risk of falls. It may increase just overall impairment in terms of cognitive abilities. So there's that impact. And because of that, there is a compromised quality of life for our patients. Again, they're carrying around very heavy symptoms and taking away some of their wellness. And with that, there's increased caregiver stress because there is a higher burden on the support system for our older adult who's carrying these symptoms. And we know that there's a link to increased mortality, and that's related to the poor health outcomes and prognoses, but also to the higher risk of suicide. So, wow, that was a lot, right? And it's, I hope, highlights the importance of identifying substance use and mental health among our older adults early, doing prevention, if possible, identifying early. So the importance of screening so that we can treat and hopefully mitigate some of this stuff, improve the quality of lives of our patients. All right. So that was just a quick overview of the prevalence and correlates of mental health diagnoses. Now we're going to transition to talk a little bit about some of the more common mental health diagnoses and some of the related considerations to that, in addition to talking through just a couple of case examples to contextualize each of them. So let's start with depression. Depression's a big one. And we know there's a ripple effect in depression in terms of its connection with a lot of other chronic illnesses, but also the increase of falls, which is another significant public health concern for our older adult population. So addressing depression is important. We know the prevalence rate for depression, it varies depending on what population you're looking at what subpopulations you're looking at within the older adult population, with general population ranging anywhere between 1% and 7%. I just found a new citation for that. And those who are health system involved, it can rank up to even like 13, 14%. So those are pretty significant prevalence rates. It's a lot of our patients experiencing depressive symptoms. And we know that depression, mental health, substance use, generally speaking, it differs for our older adult population for a few different reasons. One is the increased rate or the increased prevalence of those other chronic illnesses that we touched on earlier. And the other is that depression is oftentimes misdiagnosed or undertreated, as we already mentioned. So those factors may impact depression differently for our older adult patients. In addition, and I'm jumping all the way to the bottom of this slide, one of the other more unique nuances when we're screening for depression with older adults is that we're more likely to see complaints about physical symptoms. It's those somatic symptoms that we want to be mindful of that might give us an entry into talking about some of the other depressive symptoms. But the complaints about aches and pains or headaches or cramps or problems with their GI tract that don't really have like a medical linkage or a physical cause, or that don't even ease with the treatment, like a medical treatment that may help ease some of those symptoms traditionally, those may likely be evidence of some other depressive symptoms. And as such, again, we can use those physical or somatic symptom complaints to dive into some of the other symptoms, which some of which are listed here. So loss of interest in activities that they used to enjoy, changes in weight or changes in appetite, changes in sleep, fogginess in their brain, difficulty making decisions or concentrating or remembering things, or irritability. Irritability can be another one, or that restlessness, just kind of constantly moving or not moving at all. So all of those can be symptoms of depression. And one, I'm going to jump into assessment and treatment, what from the behavioral health end of things, what we could be providing. One thing that we can be doing is the universal screening using our patient health questionnaire, either the PHQ-2 or the PHQ-9. And something that I think is, sorry, my pup is apparently talking. Give me just a second, I'm so sorry. She wanted to say hello. Right. But the patient health questionnaire is oftentimes used already in primary care and is oftentimes used as a universal screener. It's something that can give us, as an interprofessional team, a common language to talk about depression with each other and with our clients. So assessing or screening using the PHQ can be really helpful. In addition, for treatment, we get the most bang for a buck, or most folks are likely going to be referred for both medication and non-pharmacological treatments. So regarding medication, we're going to want to collaborate with our medical team. This is our pharmacist, this is our primary care physician, or any of our medical teams, our psychiatrists, our nurse practitioners, to determine what medications make the most sense for treating our depression, or the depression for our client. From the behavioral health end of things, what we're most likely going to be doing is cognitive behavioral therapy or talk therapy to help identify and challenge cognitive distortions and related emotions and behaviors, to help shift away from thoughts that are feeding depression to thoughts that are more empowering and allowing healing. We'll also be using motivational interviewing to help move away from sustained talk and depressed talk to change talk, and potentially relational therapy. So this could be couples therapy or family therapy, or just focusing on helping our individual clients work towards assertive communication, boundary setting with their loved ones. So a lot of times those factors are feeding into the depression as well. We may also refer for exercise or movement. This may mean a referral even for physical therapy or OT, or even just suggesting silver sneakers or doing yoga or something along those lines at the local Y. We may also refer for nutrition or dietetics consult and talk to them about considering their diet and nutrition, and how that might be impacting their symptoms, and how change in nutrition may help decrease their depressive symptoms. We also want to talk about sleep hygiene, and this is true just mental health. You'll notice a lot of my slides are going to be repeated when we talk about what we do, but sleep hygiene is so important, and especially we think about the changes in sleep patterns as we age. The need for appropriate sleep hygiene, sleep routine does wonders for our mental health. So having conversations about that and how we navigate that. We also may work on mindfulness training or meditation. We may also focus on, this is where we can pull in some more transpersonal work or even spiritual work with our clients to help make some of the connections about purpose and meaning. And of course, trauma-informed care. So we know as we're approaching any of our treatment for any mental health or substance use disorder, the importance of trauma-informed care approaches and addressing the treatment from that lens will be really important. All right. So let me talk through a case example, and I've done, all of my case examples are kind of an amalgamation of different clients that I've seen throughout the years, but my hope is that it kind of highlights the role as the behavioral health person within an integrated setting. So our depression example will be a male who's in his early 70s, and he was referred for a behavioral health consult in primary care setting by his primary care physician after repeated non-compliance for his chronic health issues and repeated and increased somatic complaints. And finally, that willingness to look at the PHQ and a positive screen on the PHQ. So in this particular setting, the primary care physician refers to a behavioral health who's on site. So it's a coordinated site. And upon assessment, what was found is that this patient did meet diagnostic criteria for a major depressive disorder with quite a few symptoms, including depressed mood, a significant loss of interest in activities, insomnia, irritability, fatigue, guilt, and trouble concentrating, to the point of him really being concerned about, what does that mean? Am I losing my mind, so to speak? And there was a significant impact recently for this person based on the break in his routine due to COVID. So one of the patients who had a very rigid routine every day, and it was very much thrown out the window with COVID, and that impacting his just day-to-day. And recognizing very limited contact with the social support system. So friends and family have been cut off from them for years. And again, there's increased isolation from his acquaintances because of COVID. And he just recently moved, like within the past year, after he retired, and he didn't really want to. So there's a lot of changes that had happened within the past year for this person. And he also shared historical trauma as it related to both his childhood and serving his country. So what would we do with our depression case? Well, most likely we would be approaching using cognitive behavioral therapy and motivational interviewing techniques. So we would use cognitive behavioral to help this client move towards an understanding of the connection between his thoughts, feelings, and behaviors and his interactions with others, and to start challenging some of the thoughts that are, again, feeding his depression, those really heavy depressive thoughts. We'd also use motivational interviewing to help move, again, away from sustained talk to change talk, and use mindfulness strategies to get out of the past. A lot of times depression is fed because of regrets or guilt or these things that they're seeping in from the past. So we'd focus on how to be presently mindful and get a vacation from the past, so to speak, and also work on self-care strategies to help build in a new normal or new routine, at least for the time being, that would help serve the function of stability for them and help explore purpose and meaning. It's so important to talk about purpose and meaning. He just retired and lost a big chunk of how he identified himself, and then super isolated. So we need to connect to community resources and collaborate with his primary care for potential medication options. So that may be our approach with this person. And so the outcomes with this person is that there was improvement. Yay, right? So by being able to collaborate with the primary care and use CBT, MI, and some of the other interventions for the depressive symptoms, there was improvements in medication compliance, decreased somatic complaints, reduced depressive symptoms, although still meeting criteria for partial remission, so to speak, and continued isolation and resistance connecting with the community resources and the lack of willingness to do some interpersonal work were still feeding his depressive symptoms, but he was happy with where he was at, and so be it, right? Back to choice. So hopefully that kind of exemplified behavioral health and how we may address depression. Let's talk about anxiety. All right, one of my faves. So with anxiety, again, the numbers are going to differ based on our older adults, but anywhere between 3 and 14% of older adults may meet criteria for a diagnosable anxiety disorder. It's pretty significant. In addition to that, what we know is from one study is that nearly 25% of older adults that are in the care of like an aging service provider have anxious symptoms that impact their daily function. It may not be to the threshold of a diagnosable disorder, but there are anxious symptoms present that are impacting them. And there are various types of anxiety disorders listed here. There are phobias, generalized anxiety disorder, social anxiety, panic, obsessive compulsive disorder, and PTSD. The more common ones in our older adult populations are generalized anxiety disorder and specific phobias. There are a lot of different symptoms with anxiety as well. Here are just a few of them, but you'll see that there's also an overlap or a linkage with some of those depressive symptoms. And what's not highlighted here that I want to highlight is that you may also see somatic complaints as kind of that first symptom for this too. So in addition to like down here where it talks about racing heart, shallow breathing, trembling, nausea, sweating, may also talk about those problems with the GI tract or increased stress, headaches. Those types of things would be important to keep an ear out for, and if we're hearing them, to dive a little deeper in terms of screening for anxiety. So for anxiety, there are several different like screening tools that we could be using to screen for anxiety. And again, like the GAD-7 is a common anxiety screener. And that is one that we can use, again, across professions, and it gives us a common language that we can talk to one another and our clients about. But as you'll see, the approach for treatment for anxiety is going to be very similar to the approach in treating depression, slightly different focus on what we do. There'll be the consult for medication, whether or not that's anti-anxiety meds or antidepressants to help treat anxiety. We would want to consult with the medical component of the team. We as behavioral health providers are going to be providing talk therapy, and it's going to be cognitive behavioral therapy as a foundation, again, motivational interviewing and interpersonal therapy. And we're going to want to infuse stress reduction and relaxation techniques, strategies, help build those coping skills so that they have a toolbox to deal with the anxious, the triggers that are triggering their anxiety. We also want to infuse in family or social supports to help, and potentially use exposure techniques. And this is the idea that we can desensitize by continued exposure to our stress response. So let's talk through a case example in a similar setting in a primary care, integrated care setting. So for our anxiety case, we're going to be working with a female who's in her mid-60s, and she was referred to behavioral health consult after coming to her primary care because of heart palpitations and worries related to those, and then screening positive using that GAD-7, that anxiety screen. What we learned on the behavioral health side upon assessment is that this patient has experienced a ton of stressors recently. This includes a partner recently retiring, having hours cut at work, having a grandchild who recently relapsed, being cut off from their own child, and lots of recent regrets popping up about cutting off from family of origin and friends and other social supports, feeling very lonely, and recognizing that a recent trigger triggered a lot of intrusive thoughts about a history of sexual trauma. So upon assessment, we learned that this patient met the criteria for generalized anxiety disorder. A lot of different symptoms were involved here. Lots of worry. That feeling of doom was overwhelming for her. Very restless, very irritable. Brain was a fog, racing thoughts, everything's kind of all over the place. And again, a lot of somatic symptoms with the heart palpitations, difficulty breathing, those types of things. So as the behavioral health provider in the team, we would do, again, very similar things as we did for a person diagnosed with depression, just from a different angle to treat the anxiety. We'd use cognitive behavioral therapy to challenge those thoughts and feelings. We'd use motivational interviewing to move towards change talk. And we're going to definitely infuse lots of relaxation strategies. So teaching diaphragmatic breathing, teaching progressive muscle relaxation, teaching mindfulness strategies or meditation strategies, using guided imagery or different relaxation strategies such as those would definitely be infused to get a break and a vacation from that anxiety. We'd also talk about the technique of scheduling worry time. It's this idea of bracketing the time that you're allowed to worry. And it actually works quite wonderfully. We would also talk about sleep hygiene, moving the body. If you're feeling anxiety, rise up, run it out, or walk it out, right? Or anything that allows your body to move, even if it's just wiggling your fingers or drawing shapes on your legs if you're not able to move a ton, but some kind of movement. So a referral for like silver sneakers or those kinds of things would work here too. And collaboration again with the primary care. So we collaborated and met with the primary care together about medication options to help mitigate some of these symptoms. So her outcomes, beautiful stuff, included reduction in those anxious symptoms, and this included those somatic symptoms. So no more heart palpitations or any of those worrisome physical health symptoms were happening for her. And in addition to that, improvement in dealing with overall stress. So the stress was still there, and there's still financial stress from partner retiring. There's still stress from the family having their own issues, but able to navigate it better because of setting boundaries and those types of things. All right. Now we're going to turn to substance use disorders. And I have to say this, this is my bias. This is my fave, right? So I'm just warning y'all. But we know that substance use disorders is super important to talk about in our older adult population for a number of reasons. We know that nearly 1 million adults age 65 and older live with a substance use disorder. We also know that there's been an increase in the proportion of admissions of older adults into substance use treatment facilities between 2000 and 2012. Pretty significant increase there. And we know that the linkage there and treatment admissions is oftentimes related to alcohol use disorder. And substance use disorders are qualitatively different for our older adult population because there are physical changes in the body that increase vulnerability to substance use disorders and vice versa. So slowing metabolism increases sensitivity to the impact of substance and potentially the addictive effects of substance. And we know that the effects of substance use, if there's increased sensitivity, it can also increase accidents such as falls, which again is another significant public health concern for our older adults. And I already mentioned that the substance use disorder symptoms are oftentimes overlooked or confused with other symptoms of aging by health providers. So another important reason for us to be screening as we can. In addition to just substance use disorders, generally speaking, it's important for us to consider prescription medication with our older adults. So we know that older adults are prescribed medications at higher rates, which means that they are more likely to be exposed to medications that may be potentially addictive. And there will be increased risk for drug interactions. In addition to increased exposure, there's increased potential for misuse of prescriptions. And oftentimes this is accidental misuse. This could be forgetting to take medication or taking it double because you forgot, taking it too often, taking the wrong amount. These may be some of the common misuses of prescriptions. And we know that misuse of prescriptions impacts our older adults' mental health symptoms. So One study showed that over 1 in 4 adults 50 and older who misused a prescription opioid or benzo expressed suicidal ideation, and that was compared to 2% of folks who weren't prescribed those meds. So there's some kind of linkage happening here. So it's important for us to consider prescription medication in addition to alcohol, marijuana, or any of the other illicit substances that are out there related to older adults and how they may be impacting them. All right. Several different risk factors for substance use disorders for our older adults. Pain is a common complaint and common linkage between misusing or meeting criteria for substance use disorder among our older adults. So pain, so it's important for us to assess for pain in addition to screen for substance use. Physical disabilities or reduced mobility is another risk factor, or any transitions in living or care situations, a lot of just transition generally speaking. So this could be like retirement transition, or losses of loved ones, losses of identity, back to like retirement. All of those can impact or increase vulnerability to substance use. Poor health status, so increased physical health issues means increased vulnerability to substance use disorders. Chronic disease or illness, if they're already taking a lot of medications or supplements, that they are increased vulnerability. If there's an avoidant coping strategy, so avoid, push it away, or even a history of substance use. So even if it was just in their adolescence or back in their 30s, right, that increases the risk for reemergence of a substance use disorder in later life. And we know the linkage between mental health diagnosis and substance use disorders is pretty common. So if someone's experiencing depression, anxiety, any of those diagnoses, they're at increased risk for substance use disorders. And isolation is another significant risk factor. So what are some of the symptoms for substance use disorders that we could be looking out for with our older adults? There's behavioral changes, physical changes, social changes. So behavior changes similar to other mental health diagnoses. If there's a change in pattern in eating or appetite, sleep, attitude, if they're like sudden mood swings or super irritable or super agitated, seem to have lost motivation, or have like increased anxiety and it doesn't seem to be coming from anything specific, those could be symptoms. Some of the physical symptoms would be like a change in weight, noticing something different about their eyes, or any overall deterioration of physical appearance, or even smells, tremors, slurred speech, or impaired coordination. All of those could be symptoms that we could be looking out for, that loved ones could be looking out for. And then social changes, some of them are very explicit, like legal problems, getting the second DUI, right? Those are pretty explicit, but some aren't as explicit. So going through all of their money and not really being able to explain why, giving up on hobbies that they used to enjoy, or cutting off friends that they've had for so long. Some of those may be symptoms. All right. So when we're assessing and treating substance use disorders, there are a lot of factors for us to take into consideration. My apologies for the small font. One is there are several different screening tools that we can use, again, across professions, to screen for substance use disorders. And this includes things like the audit, which screens for alcohol, or we can use the DAST, which screens for drugs, or we can use the CAGE, and that's the one I'll focus on. So the use of the CAGE, or the CAGE aid, which is just a 4-question screener that asks about alcohol and drug use, and a positive screen would just mean further assessment. And so the CAGE, or the CAGE aid, we can use as that common screening tool. When treating substance use among older adults, integrated care is so important. In addition to being aware of the importance of age-specific treatments, treating 20-year-olds next to 70-year-olds doesn't work that well. The importance of trauma-informed care, so the importance of choice, self-determination, determining what happens, and the focus a lot on harm reduction is going to happen. But going back to that integration piece, oftentimes embedding substance use disorder specific treatment in medical settings that have an integrated approach will be important. And in addition to treating the substance use, it's treating the other chronic conditions as well. So everything is being addressed concurrently, helping rebuild support systems, making sure that they have access to the medical care they need, the social support system they need, the community resources they need. So helping with case management and helping them work on their own view of self or perception of self. So some of that self-esteem work will be really important. Building social support skills or just communication skills, because a lot of times those have been squelched in the midst of addiction. And we are likely going to be using both CBT and MI from the behavioral health end of things. So let's talk through an example. All right. So working with a 70-year-old female who was referred for behavioral health after screening positive on both the PHQ and the GAD. So screening positive for both depression and anxiety. And what we learned in conducting the diagnostic assessment is that this patient has great physical health. And this is something that she would just speak so highly of every meeting. Like, there's nothing wrong with my physical health. It's just all in my brain. But there's so many stressors for her. One child living with active addiction, other children living thousands of miles away, partner having been deceased for several years and having lived alone for multiple years. So a lot of stressors, a lot of isolation. Says the depression's the biggest issue, but upon further assessment of substance use, identified drinking a minimum of 6 glasses of wine a day to decompress and get away from the stress. So 6 standard glasses of wine a day is definitely binge drinking and would meet most likely a substance use disorder that the other symptoms would be present too. So in terms of treatment for this patient, there is, again, a focus on building rapport and building that care team, because just focusing in on the substance use, it's most likely going to be hit with resistance. So we want to focus on harm reduction. How can we cut back? We want to focus on rapport building so that we can move towards treatment with the care team. And from the behavioral health end of things, it's using CBT and motivational interviewing, moving towards change talk, identifying the cognitive distortions that are feeding the depression and the anxiety, the things that she's trying to cope with using that alcohol. And a big focus on identifying the drivers of alcohol use and collaborating with the care team to help treat those stressors. So for her depression, it was collaborating with her physician on what medications made the most sense for helping mitigate the depressive symptoms. It was also working on grief, trauma, and family work. So grief therapy, trauma therapy, and family therapy were all modalities that were infused into the behavioral health component of things, and helping increase those social support. So rekindling old friendships, connecting with potentially new social supports, using the local Y or local community center as a way to connect with other people. And what happened with her was beautiful. Overall, reduced alcohol consumption, not complete abstinence, but no longer meeting binge drinking criteria. Also overall improved mood. So while there were still some anxious symptoms that could use some additional supports and resources, the depressive mood had we had met remission for that, and increased social interactions. So those interactions, not feeling so isolated, helped with that too. Awesome. All right, so I talked about some of the common mental health diagnoses, these things that you're going to see in the ICD-10 and the DSM. It's also important for us to consider loneliness and social isolation, and how behavioral health and the care team can help address these mental health considerations as well. So we know that loneliness is that feeling of being alone, and this could be even if we're in constant social contact, whereas social isolation is the lack of social connections. And we know our older adults are experiencing loneliness and social isolation. 1/3 of those 45 and older report feeling lonely, and a fourth, 65 and older, report feeling being socially isolated. So these are issues that our patients are experiencing. And we know I love this quote that loneliness acts as a fertilizer for other diseases, that loneliness does impact other physical and mental health considerations. So it's important for us to screen for it and to open up dialogue with our clients about it. So what are some of the strategies we can use to help address social isolation? As providers, we can talk about it, right? So first things first is make sure we're asking about loneliness and social isolation. We can also make sure that we're connecting with our patients in whatever ways we can. We know with COVID, things have been weird. And maybe you've had to be creative on how we connect with our patients, but figuring out strategies to help them maintain appointments. And so there's that connection with them is important. Also, educating our patients is important when it comes to social isolation and loneliness, because that helps build empowerment. If they can believe they can make connections, then they'll be able to, more likely than not. And it's engaging their social supports or their tribe in the process. And this may be their family, or it may be other friends or other support groups like their church group or even like a recovery group. All right, so we talked about depression, anxiety, substance use disorders, loneliness, social isolation. It would be a disservice if we didn't highlight the importance of considering co-occurring issues or dual diagnosis. So the idea of co-occurring disorders, it's this presence of mental health and substance use diagnoses concurrently. And the data on treating co-occurring disorders for older adults are so limited. And it's been said in the literature that the older adult population that has a dual diagnosis is quote unquote a hidden population. So this importance of considering co-occurring issues in our older adults is paramount, something for us to consider. The prevalence is high for those with comorbid diagnoses. So anywhere between 7 and 38% of those with a psychiatric diagnosis will also have a substance use diagnosis. And then on the flip side, 20-ish to 66% of those with a substance use diagnosis will have a mental health diagnosis. So we can see that there is a significant overlap. From the scant research that's out there, one of the most cited co-occurring disorders in older adults is depression and alcohol use. So important for us to consider, again, how are we screening for both mental health and substance use concurrently so we can capture some of these potential dual diagnoses. And it's important to capture because dual diagnoses is associated with a lot of potential negative outcomes, including increased suicidality, and greater service utilization, increase for relapse for further substance use, or even just poor treatment engagement or treatment outcomes. So we need to consider those additional barriers to treatment. That dual diagnosis does add complexity to treatment, and figure out how can we as a care team address both diagnoses concurrently. All right, so in considering all of those components for our older adult patients, it's also imperative that we consider the caregiver here too. So our caregiver can be the one who is the symptom bearer for substance use or for mental health, or they may be the one caring for someone with substance use and or mental health. So accounting for them here is important in terms of overall mental health and wellness. So caregiving is defined as this unequal, or caregiver stress, excuse me, is defined as this unequal distribution of responsibilities of a caregiver as a result of caring for someone who has an impairment. And what we know is that the symptom clusters for caregiver stress are very similar to the profiles of both depression and anxiety. So our patients who are experiencing caregiver stress may meet the criteria for depression or anxiety, or may not, but the cluster of symptoms are similar. And it is a significant issue because caregiving or caregiver stress can have a negative impact on both the physical and mental health of the caregiver, with reports showing that nearly 20% of caregivers feel like their health has gotten worse since they took on caregiving roles, and 40 to 70% of family caregivers having clinically significant symptoms of depression. So we know that there's this impact of caregiver stress on the caregiver and on their mental and physical health. So what can we do about it? So regarding assessment and treatment, it's important for us to open up a dialogue about caregiver stress. There is a caregiver stress assessment that we can use to help open up that dialogue, or include it in our systematic assessment for just understanding the needs, the strengths, and the resources of the caregiver that we're working with. And other things that we're going to infuse in terms of treatment is going to be helping connect them to relational resources. So oftentimes they're so busy caring that they're not filling their own needs. They're not taking care of themselves. So we're going to want to help with relational care by helping connect with friends, joining support groups, or using any kind of community resources that they can. In addition to that, we're going to encourage lots and lots of self-care. So find ways to take breaks, find time to relax, find ways to get organized so that your space feels organized. It can help reduce some of the stress. Learn that no is a complete sentence. That's one of the harder ones, right? And then considering diet, in addition to time management at work or coming up with their budget. Like, there's so many different ways folks can take care of their own selves and their wholeness. In addition to that, we may encourage seeking professional help. So this could be both for their physical health and their mental health. So get that annual checkup that you've been skipping, that preventative health care. Go see the therapist and talk to them about what's happening and see if there's strategies that you could use. So let's talk through an example of caregiver stress. So I've worked with a female who was still working part-time. She was in her late 60s working part-time, very high stress admin job. She was caregiving a lot. So caregiving for her husband of 40 years who was diagnosed with dementia, also caregiving for her child who had just recently moved back home after being in a recovery setting for some time, and caring for her 10-year-old grandchild who she had custody of since she was a baby. And this person was referred for behavioral health consult due to noncompliance with her diabetes treatment and a very positive screen on the PHQ-9. So what did we do in terms of treatment for her? First is CBT and motivational interviewing, right? It's the work on those thought and emotional processes related to stress and diabetes management, in addition to caregiving, and infusing lots of relaxation training. So back to breathing, movement, self-care, and connecting with local resources to help her build that tribe she needed, the support that she needed for herself and for her system. Veterans groups were really important for this system, so we're able to connect to them, in addition to church groups and connecting with social worker. And we looped back to the primary care and other members of the team, including social work, nutritionist, again, primary care, about how to navigate some of those additional stressors and find strategies to mitigate them. So what happened for her? She was willing to make those social supports to help with caregiving, which allowed taking some of that pressure and stress off of her, and gave her time to start taking care of herself, which meant that she could actually manage her diabetes. It was quite beautiful, and overall decreased distress. All right, so considering all of those pieces, let's dive in just briefly, knowing that I'm out of time. I'm going to dive in very briefly about just considering some of the additional assessment, treatment, intervention strategies that we'd want to consider in terms of how the behavioral health provider is playing a role here. So we'll talk about the importance of preparing health professions to meet the specific needs of older adult population, in addition to health promotion and the different interventions we use. So in terms of preparing health professions to work with older adults, we know there's importance for training. That's the beautiful part of the GRC. It's a beautiful part of GWEP, of really opening up interprofessional training to work with older population. And the piece that I really want to focus in on here, we know that there's importance of developing sustainable policies that are age-specific and age-friendly. We also know there's an importance of developing age-friendly services and settings, and there's importance of teaching about advocacy. So for behavioral health, this is just my second soapbox. There's limitations in terms of what behavioral health providers are covered under Medicare. There's a lot of federal advocacy happening, but what that means is sometimes that limits access to behavioral health providers for our older adult population. So if our certain behavioral health providers aren't covered by Medicare, and that's what insurance our patients need to use. We have to figure out other strategies to mitigate that barrier to services. So it's important for us to teach our behavioral health professionals how to advocate for the opportunity to work with this population. And in terms of health promotion, it's important for us to consider, and something that as all of us as health professions, but also from the behavioral health end of things, is to work on health promotion and increasing those conversations with our clients. So screening for the basic needs, are the basic needs met so that they can work towards health promotion, and something we all can be doing. And again, talking about their wholeness, the wholeness of the person that we want to address from the behavioral health end of things and from a care team perspective, the wholeness of each of our clients and their different dimensions of wellness. So each of these components will likely bring in to talk therapy when we're working with clients, no matter their age. And as I already mentioned, I just wanted to highlight again that that when we're working and intervening for mental health and substance use, oftentimes it's psychosocial interventions, talk therapy like CBT, motivational interviewing, trauma-informed care, and medication that are oftentimes recommended, in addition to integrated care, using the care team. That's how we offer the opportunity for optimal symptom management. And highlighting the importance of trauma-informed care with our older adults. We know that our older adult population, they have higher rates of lifetime trauma exposure. Increased trauma is linked to increased mental health, physical health symptoms. And that change over the lifespan, changes in older adulthood, can trigger trauma from our patients' past. So to be informed of what trauma-informed care is and to infuse that into the work that we're doing together. My apologies. And I'm going to jump through these ones super quick too, my apologies, but recognizing that your behavioral health team members are a great contribution to the integrated care team, and that there are all types of us that can serve the role of helping with the behavioral health of our older patients, and that runs the gamut from psychology or counseling, focusing on individual work, or even marriage and family therapy or medical family therapy, focusing on some of that interpersonal work, in addition to peer support specialists who may be in recovery themselves, who can provide some services and supports for our patients. And recognizing that there's different levels of integrating behavioral health into physical health, and that just the sheer importance. If we're doing something, it's better than nothing. So I myself have had the experience of working both levels, levels 1, 2, and 3, with 3 being my favorite. So, and I would love to experience 4 and 5 eventually, but recognizing that importance because there is the linkage between physical and mental health with our patients. All right, my apologies, I'm going slightly over, but I hope this was helpful for you all, and I want to open it up for questions and dialogue.
Well, thank you, Rikki. That was, you can just see your passion come through in your talk. So I really appreciate your sharing today's topic with us. I see we do have a comment from Parul Chowdhury in the chat box. Parul, do you want to unmute and ask your question?
Sure. It was just a question about, could you just comment on the cultural differences in perception, presentation, and treatment of mental health disorders, especially in this population?
Yes, thank you so much for this particular question. So there is an important component for us to consider here is multicultural competency in the work that we do. So it's recognizing that each and every one of our patients who comes through the door walks in with their own perspective, their own intersectional identity, and their own understanding of what mental health is or what substance abuse is. And so it's important for us to take a culturally sensitive and trauma-informed approach to that and ask, what is your understanding, or what does your family culture or your ethnic culture bring to the table here in terms of understanding you. The approach that oftentimes in mental health, the approach is very collaborative and saying, you're the expert in your life. I just bring this therapy expertise. So help me understand your perceptions and your life and how you understand things so that we can work together on it. I think the big piece is being culturally sensitive and opening up the dialogue. I appreciate you bringing that question up. Thank you so much. Did that answer it?
Sure. And I think the only thing that I would probably like to add is that a lot of cultures have a lot of stigma associated with mental health disorders. So, I mean, some even in the US. So just sort of understanding and acknowledging that, and knowing that just because somebody's resisting treatment may not be that there may be more to it than just saying, hey, I don't want the treatment.
Very valid point, and I appreciate you bringing that up. It's important to consider how do we language so that we are sensitive to the perceptions, understandings of our patients without being too pathological or labeling.
Mm-hmm.
Does anyone else have any questions for Rikki?
This is Sue. Just adding on to that other conversation. I was wondering, Rikki, if you see that just in older patients as well, as they don't, not even a particular culture, but I find that I sometimes run across people that don't want to be told they have depression or told that they are, have clinical anxiety. And if there's any tips you have of handling so that we don't label them with something that they're uncomfortable with, but still work with them to get some help. Is there any tips that you can give us for that?
Thank you, Sue, so much for that question. And yes, it's that cohort effect, right? So research has shown us that cohort effects and stigma on mental health, and that older adults are more likely to carry a very negative stigma about mental health diagnoses, especially depression and anxiety. So may be very resistant to the label, so to speak. So some approaches to take would be, again, a collaborative approach, but asking, okay, what are the symptoms that are bothering you? And then talking about that cluster of symptoms, it's that your stomach's messed up all the time and you're racing thoughts, like your brain's not slowing down for you. How's that impacting your life? And then doing some motivational interviewing, like strategies. One of my favorite is the provide, elicit, provide, elicit, where you ask them what they know about mental health or what their thoughts are about mental health, get their perspective, and then do some psycho ed about it, and then open it up for dialogue and feedback about what they think about what you shared. So taking that collaborative approach can be really helpful in opening up conversation and acceptance. I think the most important thing isn't acceptance of a label or a diagnosis, but for clients to say, I'm struggling with this symptom, this thing, and there's this cluster of symptoms that's driving my life crazy, and I need to feel better. And if we can approach it using that frame, that can be helpful, I've noticed.
Yeah, I like that very much. I know we always have trouble getting people to go see mental health providers, and I do like that, framing it around a particular symptom that might be related. So thank you.
Yeah. And
Can I add to that, Rikki? Sorry, if you don't mind, this is Dr. Chowdhury.
Yeah, go for it.
Sometimes what I have found to be helpful is saying, to take the stigma piece away, saying you address your blood pressure, your diabetes, whatever. So I treat it the same way, so sort of putting it in that framework. Or the flip side, also saying, okay, the symptom's bothering you. Do you want to do something about it? Tell me that point in life when you want to do something about it. And so for them, that sort of puts it into perspective, saying, okay, yes, this GI symptom may be bothering me, but maybe I can still do the XYZ I want to do. But now when it starts to affect that piece of it, maybe I'll address it.
Love that. So like kind of a looking forward activity to when do you know you're going to want to address this kind of thing is a great idea. I would add to both of those as I was reflecting, as I was listening, I go back to highlighting the importance of integrated care or just interprofessional collaboration. So my experience working with older adults, it was very minimal until I was in an integrated setting, partly because older adults will trust their primary care physician in most part, and they'll accept the consult to behavioral health. And once we're able to meet and build rapport and break down some of the barriers, more likely to be accepting of working with a therapist. So that importance of kind of the warm handoffs and the connectors is super important. Another way is through couples work or family work. So as a marriage and family therapist, I would say another way that I've been linked to older adult patients is by them being dragged in by their partner or being dragged in by their kid. And then again, building rapport and then helping them figure out what they want to do to feel well.
Thank you. I like all of those methods. Those are all great ideas.
Thanks.
Anyone else have any comments, questions? And it doesn't have to be just about the presentation. It could be about LMS, anything for the GRC. We are in week 5. So if you haven't been able to get into the LMS, shoot me an email and I will resend the invitation.
I have one more question. This is Dr. Charbri again. Can you address specifically teasing out sleep issues that are normal with aging versus that could be related to mental health issues?
Sure. I think this one, I think sleep issues is just challenging, period. For a number of reasons, especially exacerbated for older adult patients. I think part of it is the best way to approach it with determining whether or not it's linked to maybe some distress from mental health or substance use is timelines. Determining when were there these sleep disruptions? When did you go from sleeping 5 hours or taking 4 hours to sleeping 16 hours or vice versa? Or when there's those big differences, it's easier to denote, but having breaking down timelines for their symptoms can be helpful with denoting some of those differences, and collaborating with their physician who probably has a more clear history on some of the physical stuff, or may have more clear history on some of that. Like a collaborative meeting can be helpful for that as well. That's what came to mind. I don't know if anyone would want to add to that.
I guess a specific area where I run into trouble is, let's say I'm treating them for depression or anxiety, and we're just talking to sort of gauge where they're at, and sleep is still an issue. So it's like, well, is it because that I need to amp up therapy, or do I need to, is this normal you? And sometimes they don't know the answer to that either.
It is a tricky one, and I concur that piece of maybe they don't know, and figuring out what is typical or normal for them can be a challenge when there's so many other factors at play. And determining, I think it's having the conversation about how much is this impacting you, and is it linked to other components that we could be working on, would be a worthwhile approach, I guess.
This is Sue again. I'll just comment because it just seems like there are so many older patients that have problems with sleep. And I know in the literature, they say it's not normal, but there are changes in the sleep cycle. So I think part of it is normal, but not necessarily something that you don't want to treat. I don't know. I always start with a non-pharmacological approach. And it's just always amazing to me how many people don't have good habits related to sleep. Caffeine is probably the biggest thing that I come up with, that you handle caffeine differently as you get older, and people keep on taking their caffeine the same way and they run into problems with that. But always seems like no matter whether or not it might be, treating the depression and anxiety might help to sleep also. at least I tend to take an approach, well, let's at least do those things that aren't going to cause harm, hopefully, the non-pharmacological things, and perhaps melatonin, because there is some information that melatonin excretion decreases with age, that a low dose of melatonin may help as well. So just kind of my thoughts.
Those were helpful thoughts. The other thing that popped into my mind is like this is a suggestion, non-pharmacologic suggestion is guided imagery for sleep or meditation. Although a lot of I've experienced a bit of pushback with mindfulness and meditation. I have to do a bit of psychoed regarding those approaches. But when they're accepted, like guided imagery or meditation to help with sleep, to help with calming down the anxiety or calming down the brain when we're going to sleep, seems to be pretty helpful too.
I think the big one I run into is turning your TV and phone off. That's like, people have never done that in their life. And like, you're telling me to do what?
Yes, that's another
Absolutely.
good point.